Bismillah ar-Rahman ar-Rahim. Then we are going to talk about the imaging of the knee, and first I will give you some idea about how to examine the knee by MRI, and these are usually the indications: the presence of pain, history of trauma or swelling or suspected infection or tumors. And in order to examine the knee by MRI, and you should use the surface coil. The surface coil is put very close to the part to be examined, and the ideal surface coil does not move with respiration.
What is the function of the surface coil?
Yes, the surface coil is, let's say, the imager or the apparatus which can take images. If you use the surface coil in the machine itself, it will be away from the knee. Then you got very small images and bad resolution. But if you put the surface coil adjacent to the knee, then you will get a bright image and a very good resolution. And you remember we have the different machines, the closed magnet, the open magnet, and this is very good for the knee. This extremity magnet, and you can put the limb there, and this coil is very good because it's very close to the knee, and you expect to have a very good images. And this is the way how can we apply this surface coil. It can be opened, then you put the knee, then you close the coil, and you put some fixators beside the knee, and this coil is connected to the apparatus, to the main machine by this wire, so that you can produce the images, and you can collect the images on the film. Then, if you look to the MR of the knee, you can see sagittal images and coronal images, as well as axial images. All the kinds of image we can have. Then, how can you know the T1 from the T2? By fluids. The fluids are black in the T1 and they are bright in the T2. But not every knee contains fluid. There should be some effusion. If there is no effusion, what do? You go to the fat, which is opposite to the fluid. Okay? Then the fat is bright in the T1 and the black in the T2. Then you can see that here the fat is more black, and this is also T2. And here you can see the fat is very dark, and this is also T2. Then whenever you see that the fat is black, this is T2. But according to the color of the fat, we have three types of T2. The first one is the usual T2. The second one is known as gradient image. The third one is known as a stare image. In a stare image, the fat is very dark. In the gradient image, the fat is little bit brighter. Then in the T2 weighted image, the fat is relatively dark compared to the T1 weighted image. Okay? Then, if you look here, and you can see that the fat is bright, and this can happen in the machines with high power. You know that the power of the MRI is measured by Tesla, and the low power machines are 0.2, 0.3, 0.5, 0.7 Tesla. And the high power machines 1, 1.5, 2, 3 Tesla, and we have 3 Tesla here in Egypt machines. Then if you have a high power machine, it will not suppress the fat. Then you will see the fat in the T1 similar to the fat in the T2. It's almost similar. And like this. This is the fat in the T1 and this is the fat in the T2. They are almost similar. And you cannot see the change of the fat if the machine is powerful. Then you should go to the fluid. And you know that the articular cartilage, which is the cartilage covering the femoral condyle and the tibial condyle, should contain water. The articular cartilage should contain water. Then the cartilage will be black in the T1 and will be bright in the T2 weighted image. And this is the way. Then, what are the things which appear black in the T1 and bright in the T2. This is fluid. Okay. Examples of fluid in the human body: the CSF, synovial effusion, urine, the vitreous in the eye. Any fluid in the human body will appear black in the T1 and bright in the T2. What is the opposite of the fluid? It is the fat. Examples of the fat in the human body: the fat in the bone marrow, the fat in the subcutaneous area, the fat below the patella. All these fat will appear bright in the T1 and less bright in the T2 with the image. Okay. And this examination is known as kinematic MRI. Why kinematic MRI? We mean we examine the patient during motion. Then we are not able to examine the patient while walking. Then we simulate walking by putting this machine in between the patient's legs, and this machine works with electricity. It flexes and extends the knee. Then we use a smaller surface coil to enable the knee to be extended and flexed. Then we can image the motion of the knee in order to see any abnormalities. This is known as kinematic MRI. Then in order to look the knee, you should ask yourself, what are the items that can be evaluated? And you know that you have meniscus, the medial and lateral, cruciate ligaments, anterior and posterior, tendons like the quadriceps and the patellar tendon, and bones and the synovial effusion. All these structures are assessed in the sagittal images. Then what is the value of the axial images? It is assessment of the patellar retinacula, the coronal images, assessment of the collateral ligaments, as I will show to you. Starting first by the meniscus. And you have a medial meniscus and a lateral meniscus. And you know that the medial meniscus is banana shape and the lateral meniscus is C shape. And you also know that the posterior horn of the medial meniscus is larger than the anterior horn, while the horns of the lateral meniscus are almost equal. And you know also that the meniscus is thick from the periphery and thin from its medial edge. Then if you cut the meniscus, you will see a triangle. And like this. This is a triangle and this is the triangle. The normal meniscus is black in the T1, in the T2, in the gradient, in the stair. The normal meniscus is black in all MR images. Then you know that this is the anterior horn and this is the posterior horn, because in all MR images the patella is to your left side. The patella is to your left side. Then this is the anterior horn and this is the posterior horn. Then you want to know which meniscus is this one. Is it the lateral or the medial? And you know that the identification of the medial and lateral is by the fibula. If you see the fibula, then you are cutting in the lateral meniscus. And here is the fibula. You see, this is the fibula. Then this is the lateral meniscus. But if you do not see the fibula, then you are cutting in the medial meniscus. This is one issue. The second issue is, I have said that the posterior horn of the medial meniscus is larger than the anterior horn. Then, if you see the anterior horn is smaller than the posterior horn, and this is the medial meniscus. But if you see that the horns are almost equal, then you know that this is the lateral meniscus. Then, the lateral meniscus is identified by the fibula and by the equal horns. The medial meniscus is identified by absence of the fibula, and the horn posterior is larger than the anterior one. Then, if you look to this image and you are cutting here, you will see the posterior horn and the gap, then you will see the anterior horn. And here, this is the anterior horn and the gap and the posterior horn. What happens if you cut here? You are cutting in the meniscal body. You will not see any gap. You will see this appearance. And this is the meniscal body. Okay? Then this is the meniscal body. And this is the anterior horn. and this is the posterior horn of the medial meniscus. Look at this is the lateral meniscus. This is the anterior horn and the posterior horn, and this is the meniscal body. Okay? Then if I asked you about this meniscus, what do you think? Medial or lateral? Medial. Yes. Why? No fibula, and the anterior horn is smaller than the posterior horn. Good. Then, what do you think of this meniscus? Medial meniscus. And this part is the anterior horn, and this is posterior horn, and this is the meniscal body. Okay, whenever you see that there is no gap, this is the meniscal body. Okay, then which meniscus is this one? Lateral meniscus, and this is anterior horn, and this is posterior horn, and this is the meniscal body. Okay, which meniscus is this one? Medial meniscus, and this one medial also. Okay, and this pulse sequence is T1, and this is no. Which one of the T2? T2 original, gradient, or stair? Original. Original is more brighter than this. This is gradient. Okay, this is gradient. Okay, then which meniscus is this one? Lateral meniscus, and this is the fibula, and this meniscus, lateral meniscus, and this is the fibula. Okay, okay. Then if I asked you about this meniscus, what do you say? Medial. And this meniscus is normal or abnormal? Abnormal. Yeah, and you see the normal meniscus is black in all images, but here the posterior horn of the medial meniscus has an abnormality. Okay, then if the abnormality is within the borders of the meniscus, this is degeneration, and if the abnormality cuts the border of the meniscus, and this is tear. Okay, then if you want to see the cruciate ligaments, then the cruciate ligaments are present in the central part of the knee, and you look first to the posterior cruciate ligament, this one, which is cord-like structure, and you go an image before or an image after in order to see the anterior cruciate ligament, this one, which is smaller, connected to the anterior aspect of the tibia. Let us look at this MR of the knee. And in order to see the cruciate ligaments, you go first for the posterior one, posterior cruciate, this one, which has a famous configuration. This is the posterior cruciate ligament. In order to see the anterior, you go an image here or there. You will find the anterior cruciate in one of these two images, either here or there. Actually, and you can see the anterior cruciate ligament in this image. Okay, you understand? Okay, let us make another trial. This is what posterior, and this is the anterior cruciate, and sometimes you can see the anterior and the posterior in the same image. You see here, this is the anterior cruciate and this is the posterior cruciate, but the usual is you see the posterior in one image and the anterior in another image, either here or there. Okay, then if you look to these images, can you see the posterior cruciate ligament? The posterior one. What is it? Yes, this is the posterior cruciate ligament. Okay, in order to see the anterior cruciate ligament, you should go here or there. Can you see the anterior cruciate ligament? No, it's not seen. Then What do you think? The anterior cruciate ligament is either torn, if you don't see the anterior cruciate ligament, is either torn, or the examination technique is wrong. Because while we examine the patient, the operator may select a wrong angle for sectioning. Then you will not see the anterior cruciate ligament. And I will tell you how to discriminate between both conditions. Then this is the posterior cruciate ligament. And this is the posterior cruciate ligament. And you know that there are two small ligaments along the posterior cruciate ligament. One is known as the ligament of Humphrey, and the other one is known as the ligament of Wurzburg. These are the meniscofemoral ligaments attaching the meniscus to the femoral condyle. But it's not important. The importance is in the posterior cruciate ligament. Then we came to the patellar retinacula, which are the ligaments connecting the patella to the femur. And you have one lateral and one medial retinacula. In order to know the lateral from the medial, you should see the fibula. The fibula is the indicator of the lateral aspect of the knee. But usually in these sections, you cannot see the fibula. And then you go to another landmark, which is the articular surface of the patella. And you have two articular surfaces of the patella, one short and one long. And the long one is the lateral one, and the short one is the medial one. Then this is the medial retinacula, and this is the lateral retinacula. If you look to this patella, this is the short surface, and this is the medial one, and this is the long surface, and this is the lateral one. Okay? Okay? Good. Then, this patient had a torn retinacula. One of the retinaculae is torn. And you can see one, and you cannot see the other one. Which is torn, the medial or the lateral? Yes, the medial. And you see, this is the short surface, and this is the medial. And this is the long surface, which is the lateral, and the lateral retinacula is intact. Then you came to the collateral ligaments. The collateral ligaments, one medial and the other one is lateral. The medial ligament is closely related to the bone, while the lateral one is relatively away from the bone. This is number one. Number two, the lateral ligament is not seen unless you see the fibula, because it is connected to the fibula. Then, the lateral collateral ligament connects the femur to the fibula and is away from the bone. But the medial collateral ligament connects the femur to the tibia and is close to the bone. Okay? Then, what do you think of this ligament? This is the medial one. It's long and is close to the bone. Then, what do you think of this ligament? This is the lateral. It's away from the bone and is connected to the head of the fibula. On the sagittal image, if you have a lateral image like this is sagittal and this is coronal. And you cut in the fibula, in the head of the fibula, you see two black lines going into the head of the fibula. One of them is the lateral collateral ligament connecting the femur to the fibula. And the other one is the tendon of the biceps muscle. The tendon of the biceps muscle. Then if you have an abnormality in the biceps tendon, this view is very good. The sagittal view, where you can see the head of the fibula, and this is the lateral collateral ligament, and this is the tendon of the biceps muscle. Okay. Then I have said that the normal meniscus is black in all images, and if you see any abnormality in the meniscus, you are thinking of degeneration or tear. Then, in order to differentiate, if the meniscus does not disrupt the borders of the meniscus, this is degeneration. If it cuts one or more of the surfaces of the meniscus, then you call it tear. Now, we have two types of degeneration, grade 1 and grade 2. Grade 1 is just a dot in the meniscus, like this one, a dot. And grade 2 is a line. Grade 1 is a small lesion, grade 2 is a relatively larger lesion. Then, this is grade 1 degeneration, and this is grade 2 degeneration. Okay? Then, what do you think of this? Yes, the grade 1 degeneration. It's just a dot in the meniscus. Then what do you think of this? This is grade 2 because it is a larger area of abnormal signal. Then we have another type of degeneration which is rare, and this is known as meniscal fraying. And you see fraying of the medial edge of the meniscus. How this appears in the MR images like this. You see that the medial part of the meniscus is of abnormal color, but the whole meniscus is good. You see the triangle is okay and no abnormality apart from the apex of the meniscus is of abnormal color. Then you say this is meniscal fraying. It's not frequently seen in the clinical practice, but the two other types are frequently seen. Then if you see an abnormality which cuts the border of the meniscus, and this is tear, okay, and we have simple tears and the complex tears. The simple tears are, okay, first of all, you see this is the medial meniscus and this is the linear abnormality with intact borders of the meniscus. Then this is degeneration, okay. Then if you look here and you see this is degeneration and this is tear. If the tear is horizontal, it's known as horizontal tear, which is usually degenerative. And if the tear is vertical like this, and this is known as vertical tear, which is usually post-traumatic. Then we look at this meniscus. What do you think? This is degeneration because the border is intact above and below. This is degeneration. Okay. Then we came to the tear, and this is the horizontal tear, which is usually degenerative. A linear abnormality with disruption of the border of the meniscus, and this is horizontal tear. Then another example, a linear abnormality disrupting the meniscal border, and this is horizontal tear. But this is what we call the vertical tear. The vertical tear is vertical and is usually post-traumatic. The vertical tear is usually post-traumatic. Then this is another example of a vertical tear. Another example of a vertical tear. And the horizontal tear is usually degenerative, and the vertical tear is usually post-traumatic. Then we came to a third type of tear, which is known as the radial tear or root tear. Root tear means that a small part of the meniscus has torn and is no more present at its normal location. Then if you have a section in this area and this part of the meniscus is torn and is now away from its site, you will see the anterior horn, but you will not see the posterior horn, like this one. You see the anterior horn and you don't see the posterior horn. But if you have another section here, you will see the anterior horn and the posterior horn, like this. You see anterior horn and posterior horn. Then if you have the sections in the knee, in one section you see the anterior but you don't see the posterior. The following section you see both horns. Then the root of the meniscus is torn, and this is known as radial tear or root tear. And some books call this ghost meniscus. The ghost meniscus means that you cannot see the posterior horn, and this is another example. Here you don't see the posterior horn. In the following image you can see the posterior horn, and this is known as root tear or ghost meniscus. Then what do you think of this type of tear? Horizontal degenerative tear. Okay. Then we came to a flap tear, which is a complex tear. The flap tear is joining both components, the horizontal one and the vertical one. If you see a tear which is composed of a horizontal component and a vertical component, this is flap tear. And here you can see a horizontal component and a vertical component. Then if both tears are present in the same meniscus, this is flap, and they usually simulate this by the fish mouth, and you see a horizontal part and a vertical part. Okay. Then look at this. You see the horizontal part of the tear and the vertical part of the tear. Then if you see both, you know that this is flap. This is flap tear. Okay. Then we came to the famous one, which is known as the bucket handle. The bucket handle means that there is a tear in the mid portion of the meniscal body that has resulted into two fragments, an outer fragment and an inner fragment. The inner fragment will be displaced in the intercondylar notch. Okay? Then will give the appearance of a bucket handle. This is the handle and this is the bucket. How can you see this in imaging? If a part of the meniscus is torn, then what do you expect on the remaining part? It will be small. Okay? You remember that the posterior horn of the medial meniscus is larger than the anterior horn. Okay? Then if you have an MRI and they see that the posterior horn is smaller, then you know that a missing part of the meniscus is present. Okay? You understand? Look at this. This is the sagittal at the level of the medial meniscus. This is the posterior horn and this is the anterior horn. This posterior horn normally should be larger than the anterior horn, but now it is smaller, meaning that a part of the meniscus is missing. Then where to look for this part of the meniscus? Look in the intercondylar notch here. And in intercondylar notch you find the cruciate ligaments, the medial and lateral. Okay? And the posterior and the anterior. The posterior is a little bit medial and the anterior is a little bit lateral. Then if you look at the level of the posterior cruciate ligament, you will see the missing part of the meniscus. Look at here. This is the posterior cruciate ligament and this is the missing part of the meniscus. And you got this sign which is known as double BCL sign. Double posterior cruciate ligament sign. As if there are two posterior cruciate. One is the original and the other represents the missing meniscal fragment. Then if you look in the MR images and you see that the posterior horn of the medial meniscus is smaller than the anterior horn, think of bucket handle. Then go to the posterior cruciate ligament. If you see another one, then you know that you are dealing with a bucket handle tear. Okay? Another try. Look at it. This is the anterior horn and this is the posterior horn. The posterior horn is smaller than the anterior horn. Then go to the posterior cruciate ligament and you see another one, then this is bucket handle tear. Okay? The bucket handle tear can occur also on the lateral aspect and the lateral meniscus, and the appearance is different from the medial meniscus. And the lateral meniscus bucket handle tear, you see this appearance. The posterior horn is no more at its site. It is displaced anteriorly. It is displaced anteriorly. Then if you look to the knee, you will see both horns in the anterior aspect. The posterior and the anterior horn are both on the anterior aspect. This equals bucket handle tear of the lateral meniscus. It's an easy diagnosis compared to the medial one. Look at this. The posterior horn is not present in its location, but it is present anteriorly. Then if you see the both horns in the anterior aspect of the knee, you know that this is bucket handle tear of the lateral meniscus. Another example. The posterior horn is not seen, and both horns are present in the anterior aspect of the knee. Then you know that you are dealing with bucket handle tear lateral meniscus. Another example. The posterior horn is not seen, and two horns are present in the anterior aspect of the knee, diagnostic of bucket handle tear of the lateral meniscus. Finally, the meniscocapsular separation of the meniscus from the capsule. If the meniscus is separated from the capsule, you will see that the base of the meniscus is away from the capsule. And this is not enough for the diagnosis, because this type of injury should be associated with edema. It's a traumatic lesion, should be associated with edema. Then if you look in the T2 weighted image, you see some fluid between the meniscus and the capsule. This is essential for the, if you don't see the fluid, this is not meniscocapsular separation. And meniscocapsular separation is diagnosed by the distance between the horn and the capsule, and this distance is filled with fluid, meaning bright signal in the T2 weighted image. Then meniscocapsular separation does not occur on the lateral aspect. It occurs on the medial aspect only, because the meniscus is firmly attached to the capsule. But on the lateral aspect, the meniscus is loosely attached to the capsule. Then normally you will see fluid at the base of the lateral meniscus. Normal. This is not a meniscocapsular separation. But if you see fluid on the medial aspect, this is meniscocapsular separation. Then you came to the discoid meniscus, which is a lesion commonly seen on the lateral aspect. What do we mean by discoid meniscus? Is disc-like, meaning that the body of the meniscus is large and the horn is small. Then, how can you know that the body is large? If you are cutting in the knee and you see no gap, this is the body of the meniscus. Okay? If you see the body of the meniscus in three images, you know that the body is large, because the normal appearance of the body is only in one section or two maximum. But if you see in three images or more, then the body is large, then you are dealing with discoid meniscus. And here, the body of the meniscus in one image, in the second, in the third, in the fourth. Then this is discoid. In this example, the body of the meniscus in the first, second, third, fourth. Then this is discoid meniscus. And finally, the meniscal cyst. The meniscal cyst is a cyst filled with fluid at the base of a torn meniscus. This meniscus is torn. You see the site of the tear? And at the base of the meniscus, you see a fluid collection. And the fluid is black in the T1 and bright in the T2 weighted image. Then this meniscus is the medial one, because this is the fibula and this is the lateral meniscus, which is normal. But this is the medial meniscus, and you see a tear inside the medial meniscus with the collection of fluid at the base of the meniscus. Look at this example. This is the medial meniscus where a tear is present. And at the base of the meniscus, you see a collection of fluid. And the fluid is black in the T1 and is bright in the T2 weighted image. And this is what we call this meniscal cyst. Meniscal cyst. Okay?